First of all, thank you, Edat, for the kind invitation. It's a pleasure to be here today. I will be talking about digital dentistry, which is my usual topic. Trying to bring some updates, some insights, trying to talk about both the workflow and some bottlenecks that we have in digital right now and how to manage them. Digital, as most of you know, it's about planning because most of it happens on the computer screen. So you have all this tool set, which is new, amazing, and sometimes overwhelming in terms of possibilities. And just to give some context, the narrative in which we have been pursuing and using digital dentistry is this idea of copying natural shapes is something that we have been pursuing for years. This is an article in QDT 2017 where we described, we published for the first time how we were iterating a workflow in which you did all the planning, so that at the end, when you would remove the restoration out of the milling unit, you would be able to use it, because I think at the end of the day, this is the, let's say, the true end goal of digital, to create like shortcuts to enhance what we do. I see not so much, I have not so much interest in workflows that at the end of digital workflow you have to take the restoration, cut back, layer, and do all that, because for me that is most of the time just an expensive analog. The advantage of using CAD/CAM in this way is that you have one of the most important, let's say, aspects of both aesthetics and function. You can precisely copy a virtual design, and you can precisely copy shape, which is probably one of the most important parameters. The disadvantage of working in this way is that by default, you will be always working with monolithic restorations, which means you will have a less of an optical tool set than somebody who's layering. So at this moment in time, you'll have many advantages. You're gonna have a few bottlenecks, and I'm gonna discuss them both. A lot of what we have been doing and of what we do nowadays is inspired by, let's say, the context of us doing courses quite often. And all the courses we're doing live patients, and what this teaches you is that when you have 3 days to finish a case, there's very little room for error. So you have to plan accordingly, you have to do things in a certain way, and pretty much after focusing like this in courses, we got to the point where this became our everyday planning and reality, because it just it gets very comfortable in terms of control and all that. Now, every case has the same narrative, which is you have a planning phase, you have some stages there, which I will cover immediately. Like you can see here, for example, in the planning phase, you have a 2D phase where you select the library according to the face. And then you have the phase where you transfer this in the mouth here in the form of a motivational mock-up. And then the goal of the dentist is to simply follow up on that design in a way that the lab can have all the conditions to actually copy those shapes. So my focus after that is just to put the tissue according to this mockup. As you see on all these mockups, the bisacrid is on top of tissue, so I have to recontour the tissue according to those measurements, and then do the preps. We usually, whenever we do like flapless, we do it at the same time of the surgery. Again, you have to put the chamfers in the correct position according to the design, and then if all of these are met, you get to the point where you can actually copy the shapes without having the need of doing any manual alterations. So you can see this example here is simply stain and glaze. This is immediately after the bonding, after the surgery, and this is after it heals. What I want you to look at is not specifically this before and after. Rather, I want you to compare the design and the final in terms of copying ability. You can see on the left-hand side, you have a design that is on top of tissue that is obviously in a different position, at least in the buccal aspect, than the picture on the right, where you have the final design, although we're always talking and we are always using the same library. So the difference here is the position of the library and the material. But regardless, you can see how predictable you can be in terms of delivering this copy. Now, at the core of this concept is all about biometrics. So biometrics is every data that is unique to an individual or to a patient, and obviously all the shapes, all the tooth shapes, and all the data that we receive via scans, via all the modern documentation that we get is unique. And we have been working in the last years. We developed an ecosystem, a platform to manage all of this biometric data, which is probably at the center of what we do in digital. Let me put it this way: libraries, if I am to make a comparison, in analog, the basic unit of design is know-how. You have to imagine how a tooth looks like if it's missing, and you rebuild it using your vision, your skills, your experience, or if there's more, or if you rebuild a smile, etc. Now, in digital, the basic atom of design is a shape. It's quite a similar story to dentures, if you will, where you will always select like some shapes of teeth, and when you define a restorative space, then you will mount those shapes, and you generally never go in a denture and you're never gonna say, oh, I'm gonna put this central and then I'm gonna change its distal. No, you don't generally do that. What you do is you focus a lot in the beginning when you select the central. If you don't like the central, you select a new one, but you don't actually change those teeth. It's pretty similar what we're doing today with libraries. We focus a lot on the selection of the library in a way that it fits our clinical scenario. Because again, if you just working with libraries by default does not guarantee that at the end the ceramics looks the same like the mock-up, because of the fact that in order for it to look the same, you should and must not modify the library along the way. It's logic, right? So this means that when you select the library, it has to fit your desired criteria for that design. So imagine that central that you select has to have the same proportion, the same papilla, embrasure, contact area ratio, similar line angles, in order for this library being able to be reproduced from on all these steps, from initial data to 2D and 3D and 4D. Now, let me go a little bit through the steps, and again, I will be talking about two scenarios. One, which is a simple scenario, and another one which is like a a more difficult case. So we all start with data, which happens at the consultation, and then we usually go to a 2D step. The 2D step is the part where, technically speaking, whenever you're doing like a rehabilitation, it's, let's say, the smile design phase, because that's where you do a couple of things. First of all, you determine the aesthetic parameters in relation to the face and to the facial features, and you map a restorative space or a grid, which in how we do it using Smile Cloud, we can in real time turn that into a search engine for natural shapes and render it as a virtual mockup. Doing these virtual mockups, first of all, it's very fast and efficient, and simple at the end of the day. And the nice thing is you have a follow-up in 3D, because just drawing something does not mean much unless you have a follow-up. The idea is that all of these libraries you can download, which are all of them unique composition of natural shapes. And if you see them, I'm opening them here in a basic 3D software that I can simply use just to finish this mockup here if I just add the STL file, because there's a simple equation for how we're doing design today. You have your initial situation, and then by using a tool that searches the library that fits and can pre-visualize it, you can just download that specific library, and one plus the other equals design. Now, imagine that for case acceptance, you can either use this tool, which is like a virtual way of showing how the library looks to the patient, or you can do the actual design, download it, download the library, create a 3D file, and then have a motivational mockup and have an experience like this. However, you notice that I mentioned that this step is 2D. It's 2D regardless if you're doing it virtually or if you're doing a motivational mockup like this. Why? Because this mockup, being always on top of existing teeth and tissue, is not really accurate in all 3 dimensions. It's actually accurate in 2 dimensions, horizontal and vertical, because in terms of sagittal, it's always bulking out. The more protrusive the case is, the less accurate this step is. In reality, this design is precise only when you have a pure additive case, which is not really the average day scenario. I mean, it's a very small percentage of cases that are purely additive. So remember that this is an outcome-oriented step. So either you're gonna use just a virtual tool to render the library and then go immediately to design a final one, or you print it and you're gonna transfer it in the mouth to do a before and after video. Your outcome at this point, at the 2D phase, is deciding what library you're going to use according to the face of the patient and getting the case acceptance. You want the case acceptance as early in the process, so that when you invest time in doing the real thorough planning, which takes time and resources, you're already working on an accepted case. And this is just from a pragmatic point of view. In an ideal world, you would always plan all your cases to the best level of detail and then present them to the patient. But this only happens in education, where all the patients accept, right? In real life, not everybody accepts. So if you do that in real life, right, it's not really, let's say, realistic. Realistic is you need to start. You're starting, what I'm showing here, do not think of it as aesthetics, but think of it as communication. You always start with communication, because in the beginning, what you need from a patient is him or her to say yes. So basically, this motivational mockup is something that is the only use that we find is to communicate visually a certain treatment plan that involves aesthetics. However, you must always have the ideal design, which is put the library in the perfect 3D position, which means perfect 3D position means you're always going to have to reduce things, sometimes tissues, sometimes teeth, sometimes both. So the point here is that like I said, the motivational is actually the one that's optional, but you should always go and have either only the ideal or both if you're going to use communication. Now the question is, why if you go directly to the ideal one, what is the potential problem? Well, you cannot put it in the mouth because you need to cut things before that. And to cut things before that, you need the patient to accept. And for the patient to accept, he needs to see something. So you get the point. So that's why it can be two ways of doing it. Either you do it virtual, you get the acceptance there and you go to ideal, or you do like the motivational and the ideal. So once you have the ideal design, then you can create all the other guides that you need to be precise in the case, like soft tissue guides. The soft tissue guide for me is a tool to actually copy the cervical part of the tooth, not necessarily to avoid canting, because the canting part can be easily avoided by just, perioprobe and measuring on the design in the mouth. Here, after we recontour the tissue, we're gonna do the bone using a flapless technique. You can use this flapless technique whenever the bone is thin. If you wanna read more about it in this year's QDT, Paolo Cano has an excellent article about it, and he is the actual developer of this technique, which is an amazingly efficient and easy to use one, I would say. Then, if you wanna know, for example, how much to pre-prep before you put the design in, because remember, you're getting the acceptance. First you cut the tissue, then you have to reduce the teeth. Now the easiest way to do it is to simply look on the screen. You can of course transfer base acrylic in the mouth with a different color and all that, but to be honest, I just do it for didactic purposes rather than everyday purposes. Everyday purposes, I just superimpose the two STLs. I look on the screen, I check where I need to cut, and I cut. The thing here, you don't need to be accurately precise to like 1/10 of a millimeter, because it's a pre-prep. It's not the actual prep. Just have to cut so you can place your library in the final position. This is your ideal design, and based on this you will do the actual prep. Here, either use APT by Galip or use a silicone guide, or both. It doesn't really matter. Just create the right amount of space for the ceramics. Here, the prep is minimal, except the fact that we have to open contacts between centrals and laterals, because you have that tooth position issue, and it's going to be impossible to create a nice contact in ceramics unless you cut the contacts there. So you can see the narrative is always, you select a library and you always follow the library. You're going to use it first to communicate in a form of motivational mock-up, and then you're going to use it in, to actually do the prep, do the provision, everything else. And then when you go to the ceramic part, you're going to copy the same library in ceramic, mill it in monolithic material, simply stain it, and then you're gonna bond it, and this is the end result. And you can see again the copying ability that we're having nowadays with technology and with this way of working. What is very important, and this you will see more clearly in this case, and I always have this conversation with friends, you know, dentist friends or speakers and all that, because it's like two ways you can look at it. Imagine you have a complex case like this one that we're going to talk about now. Whenever your case is complex, you're going to have like multiple stages. So in traditional thinking, at every stage, as you modify something big, let's say you do the ortho or you're going to do grafts or tissue or whatever, you need to redesign according to that situation. So most of the time we're used to using design as a reactive tool to how the case progresses. You're going to do a design in the beginning, and then after ortho you're going to do another one, and then you're going to do another one after the graft, and so on and so forth. But what are the chances that your initial design will actually look like your final design if you are always using the design as a reactive tool, adapting design to the situation? I mean, if you want to be predictable, I think that you should consider doing it the other way around. At every stage, relate the clinical situation to the design and try to use the design as a scaffold or as a blueprint to understand where to correct. So you can see here there's a case with multiple problems, skeletal problems, dark tissue, occlusion, aesthetics, the whole 9 yards you have here. So this is a more, let's say, other end of the spectrum case that I want to show you, simply because the narrative of the simple case everybody's using to showcase something, but we need concepts that work pretty much in any scenario, such as more complex like these ones. So you can see here again, let me just give an example of how this works. What I'm showing you now, it's again the way that the technology that SmileCloud works, which is, let me pause a little bit and give some background. We have been involved in developing this, and we have always believed that in order for something to work, it has to be extremely simple, yet you should have the efficiency and the options that you need. And for this, we have been using and investing a lot into artificial intelligence. But artificial intelligence, let me very clearly describe how I believe it should be used. I don't want artificial intelligence to replace or to take decisions instead of me. No, I don't think that would be a good idea, and I don't think that would make a better world. However, I want AI to speed up the things that are boring in the process, because in every software, to get from one point to where you want, you need like a certain number of clicks. Like, I don't know, it can be 50, can be 100. And the thing is, the first 80 are usually the boring ones. You have to always go through next until you get to where you want. And then when you get at the end, you can actually take some decisions. You can have some value from what you're deciding to do on the screen. So what we want to do with AI is just get there fast, so every time and every click that I spend in the software actually is meaningful. So here you can see we use things like facial recognition, artificial intelligence, and algorithms to do things like, first of all, we are detecting the face. We are auto aligning it. Of course, you can modify that if you want. Let me just go like this. So you can just modify if you want. Then the lip, play the, oops. So the face is detected automatically. What is this? Then the lip contour is again detected automatically by the system. You can just adjust if you want a little bit. Then restorative space, which is all the aesthetic parameters packed into like one simple grid interface, is automatically placed on the face using generic denture principles, which is usually very accurate. So you get in like 4 clicks to the point where you have like an editable library and an editable design where you can just go in, select shapes, move things around, take decisions, and everything is like reactive to what you do. So the difference to most softwares is that instead of me spending time to do these things, I'm always at every step of the software, I'm working on a draft, which is already there, and I can just alter things. Also, the nice part working this way, you can see at the end of the design process, you usually have one design, one mock-up, one version prepared for that patient. Here, what we essentially have, once we put the aesthetic parameters of what we want in the case, we have a search engine of design. So you can go through tens and hundreds of design and subjectively choose with the patient. So there's a lot of advantages in working this way. Now, depending on the discrepancy in this type of cases, you can either go ortho or pros. And here, the need for ortho is obvious because of the skeletal discrepancy. So we need to expand the arch. We need to impact the maxilla to reduce the vertical dimension. As you see, like the vertical dimension here is like too high. If we would go back, you see that there's a lip incompetence. So all these things suggest that we should go for a surgical approach to ortho. So what we're doing then is, once we are doing that design with the patient, it becomes like one of the pillars of collaboration. I would just send this to the orthodontist. Orthodontist would turn it into a setup where, you know, you would plan everything accordingly. And then the approach through ortho is usually always start with the TMJ and muscles, and here is like splint therapy to create that muscle passivity and to have like a stable joint. After that is the skeletal part where we do like the expansion of the maxilla, and after that is the tooth alignment, which uses like indirect bonding based on the setup we just created. And the last part is the orthodontic surgery, which uses the occlusion as a splint. And this is the result that I got after the surgery. Now, from this point, again, what am I going to do is, first, I can notice that most of the problems are gone. I still have issues with things like color, which is one of the bottlenecks we will cover. Another bottleneck is, how can I go back to my original design? How can I be predictable here? So remember, I had an initial design. I had the library already selected. So now I can go back again to that library, and I'll show you how you assemble everything in one project according to your initial. So what we're gonna do is we're gonna use Exocad here as the main software for planning. We're gonna import the library from SmileCloud. We're also gonna use patient-specific motion, which is recorded with Mojo software, which is an amazing tool for any, I would say, if you're doing rehabilitations, is something that you should definitely look into if you're into digital. It just expands your options so much, especially in the functional aspect of it. So at this point, we have all the patient-specific motion, we have the current situation, and we have the library and the initial planning. So we're going to position first the library in the ideal position and virtually delete what needs to be deleted. We always start with the maxilla, with the upper jaw. And here you can see exactly how this turns out. Now, the moment that this is done, you can see again, we have the upper in position. And right now we have a few contacts because there is a little bit of a cant of a difference after the in the ortho from what was planned with what resulted from the surgery. So regardless, here I will always adapt the situation to the design, not the other way around. So then we need to correct this small part. So we're going to take a library in the lower, and again we're pretty much going to do the same thing, erase the parts that needs to be deleted. And once we do that, the first thing we will focus about the position of the library, try to create as many cusp fossa scenario as possible in static position to have like a a very stable static occlusion, which is our initial point of motion for all the other functional movements. So the moment we do this, then we go to the recorded patient-specific motion. And remember that this patient has been through splint therapy, is already stable. The only thing that we are improving now in the occlusion is creating, like a much more stable occlusion and in fine-tuning it in dynamics. So in this point, we are not using an articulator, we're using the pure motion of the patient because I want to copy his occlusion, technically speaking. And at this point, we have, you can see the final project virtually before we even start the case. Now, we can print this model. And again, in this case, you can see the right one is what you always need in every case. And in this case, just to make sure, because I need to do some corrections, I also asked them to make me the same version, but in the motivational form that they move the library slightly in front. The reason why I need to do that is because I need to just check. It's been like 1.5 years of treatment, so I need to make sure that everything's okay. So at this point, where I'm placing this in the mouth, I'm using all these tools like the black marker to paint the teeth and pink composite to simulate where we're gonna mask the gingiva, and we're gonna validate it with the patient, make sure that everything is okay at this point. And then the second that we are convinced that this is what we want to do, then I go in and adjust, and I would first cut the black areas and then immediately after do the tissue according to the design. Now, one thing I always do it after this tissue recontouring and also with the prep. Here again is the technique with the flapless bone. And this is what I was talking about what I always do is I always check, and I advise you to always do this check specifically in the centrals, because if you make a mistake in the lateral, it's manageable, but in the centrals, if you're going to have any mistake, it's the first thing you're going to see. So always measure on the printed model with a perio probe, and then go in the mouth after you cut the tissue and measure from the new zenith to your future incisal edge, which is on the silicone index, and make sure you have the exact measurement, because if you have any error there, your shape will be different, obviously. So the last thing, we have to remove the old restorations. In here, you can see another bottleneck, which is color of both teeth and tissue. And it's always a problem when you're using monolithic restorations. Like if you would layer and have a good technician here, you wouldn't care. But if I would layer here, I would lose all the shapes from the library. I would use the precision that I got from planning with Mojo. No? Even if you layer a little bit, don't think that is 0.1 or 0.2, it doesn't matter. It does, because you can get to an extreme level of precision in the virtual, and the problem is the manufacturing method. You can, technically you have to opt. Do I go for shape and then it's monolithic, or do I go for optics and then you have some adjusting to do in terms of shape, and you lose a little bit of the plan. Now there are many things here that I don't have time to cover now. You can go in and check according to the original design. You can always align situations and see how it evolved according to your original planning. But here, let me just focus on how to manage this situation. What we are doing here, and this is an article that's going to be published in the next QDT, is imagine, in order not to have a problem at the final trying, we should really address the main issue, which is we have two issues here. You have the color of the substrate, so that is the real problem. And second, the difference in thickness of the ceramics, because ceramics, depending on thickness, in monolithic, same block, different colors. So what I did here is I prepped two chamfers. One where I want my future crown to start, another one where ferrule starts, so 2 mm more incisal. Here's I took an impression just to take a picture of it to better show you, because on the scan it wasn't so clear. Why we take the two chamfers? Well, for two reasons. One, you want to preserve ferrule as much as you can for structural integrity. And second, because what we're going to do is we're going to ask the technician to make like the final design in a transparent PMMA, which is the final design on the outside. And on the inside, you will have the ideal abutment that will be ensuring the uniform thickness. And you can see this transparent PMMA is used as a carrier for the material that we're going to use to block the substrate. So here we're going to go with the adhesive steps. We're going to sandblast, silane that metal, and then you're going to etch, bond. And here it's like an opaque resin that I found in the lab. I don't really know what system it is. It doesn't matter as long as it's white, just to block that metal. It does the job. Of course it has to be a resin. And then I use like Tokuyama OPA2, which is for me one of the best composites for this job, because it has both chroma and easy to handle and very nice opacity. And then as again, going back to the two chamfers now, because I have two chamfers, these copings will always have one position. If I would only prep one, now you would have like it's wiggling around and you would not be sure how to position it. And then, you could lose all the work. And then you just take like an ultrasonic tip or a burr, and you either cut it or heat it with the ultrasonic tip and remove this plastic coping. And you get a beautiful abutment that both copies both manages the space and the color of the substrate. This is very hard to do by hand. Very hard to do precisely in terms of thickness, not in terms of, just putting something on top and then grinding it. It's just, I think, a clean way to do it as a technique. Now you can see in the laterals, we still have some dark areas, and we still have some dark areas in the tissue because we opted in for preserving ferrule. This we will manage with staining inside the restoration. You can see those areas that cervical millimeter, you can put like some inside stain. In this picture, you have like an exaggeration of how much stain you should use. Again, for didactic reasons. In reality, you have to put very little. Okay, that's the thing about staining, has to be subtle. So once we have the trying and we're pretty much sure that everything's okay for what teeth are concerned, then the last part is managing the tissue. And just before bonding, we had Gustavo and Marcelo Giordani that what they did is they took like the soft tissue grafts and create like the pockets, put some stabilizing sutures. We use this to, again, as a reminder, to block the color in the dark roots. And the moment that we have the stabilizing sutures, then we can place rubber dam, bond everything else, clean very well, and then put the final sutures that pull the tissue over the contact points. And this is how it looks like when we remove the sutures after 14 days or 10 days, don't remember. And then here you have a picture at the same time with polarized light, just to show how the color was managed. Then we had the lower at the same time, and this is a picture like 6 months after the treatment. And here you can have like a before and after. So learning points is, doesn't matter if the case is simple or complex. If there's a solid narrative in a way of using technology, it should work for both. I think that if you want to be predictable, instead of adapting all the time design to the steps, you should adapt always the clinical steps to design. I think using natural shapes should be a standard for everybody who's into CAD/CAM, at least in terms of you should master it. Sometimes you'll use it. Most of the time you'll use it. Sometimes you'll opt for something else, but it should be in your pocket anytime, because it's what gives you that 85%, like streamline in cases like this. It just takes away the stress of many things, and you can focus on details. And also, as you can see here, the efficiency and the speed of cases is completely different, because in both examples here you can see the prep and the surgery at the crown lengthening is in the same session, and the graft and the bonding is usually in the second session after the lab. So what we're actually doing is we're using the design or the library or the shapes as a scaffold to guide the healing. So instead of doing a procedure, waiting for it to heal, and then readapting the design, you do the procedure up to the final design you want, and you use that as a healing scaffold to guide the healing for what you need. You're going to be much more likely to get to a nice result, I think, that way. I mean, we do it like this for implants. If it works for implants, trust me, it works for teeth just as well. So pretty much this is what I wanted to cover today with you guys. I want to thank you very much again for the opportunity, and I will be here shortly for your questions. Thank you very much.